So at this point, we have aggressively suctioned, we have passed a bougie through to try to relieve any mechanical blockage, and we have flushed following with our suction. It's also important that I mentioned, and I didn't earlier, that if you apply supplemental oxygen in any form to the nose and mouth, you need to make sure that your cuff is down. Otherwise, it will not be able to pass past the trach. And one other tip that you can try is if this has become dislodged in any way, as if, obstruction of the device itself internally is not the issue. Sometimes if a patient coughs slightly, this will move, coughs violently, this will move slightly. Or granulation tissue can get over the covering of the very distal end of the trach. So trying to manipulate this slightly by turning it, pushing it, making sure it's all the way in, or trying to pull it out just slightly can give you some improvement clinically. So after you've done all of those things, if you are still in trouble and the patient has not improved clinically, then you need to think about replacing this trach. And you can do that with either another trach if the patient has one on hand, or you may need to use an ET tube. So you can look on the flange, and that will typically tell you the inner and outer diameter and guide you as to what size tube. But if the patient does not know, if the caregiver doesn't know, and if there's nothing written on this, or if the tube has, or the trach has come dislodged completely and they can't find it or something for some reason, then a 6/0 tube is typically what we recommend you start with. So, and it's also worth mentioning at this point, there is no protocol to guide you, both in the state and at HEMSI. So we are recommending that you call us if you are going to insert anything in the neck or remove any of that outer cannula from the neck. So I also recommend you go bougie first in all circumstances, because there's really no reason not to. So whether you're going to pull the trach out and replace it, or if it's already been removed and you are going through the stoma, I want you to use the bougie. Okay, so you will simply place this, and you should get the tactile feedback that you're in the trachea, because you will feel the tracheal rings. Okay, so once that's in place, you can, and this is a little tricky because this guy, there we go. You're going to pull the trach out, okay, and then you are going to load your ET tube, and this is going to slide over, right, ideally into the trachea where the trach came out of. So how deep do we go, okay? And the answer is not much, because you're already past the level of the cords, and if you look, this isn't very long. So what I could have done is, when I pulled the trach out, I could have just left the bougie in place, compared balloon to balloon, and marked about where I want to go. But I also just know that this is about the level that I want to go. But measuring it always can be done. So here we are. Now we're going to inflate our balloon, and we can bag right through this. Okay. People always ask, can I cut this? Yes, you can, but you don't want to cut below the level of the balloon. If you want to cut above it, you can, and just move the adapter down. That's fine, but you don't need to. And so if this does not fix your problem, then likely the trach wasn't the problem. And so I think it's worth mentioning that patients who have trachs also have COPD exacerbations, asthma attacks, they get pulmonary embolisms, right? There is still other things that can cause respiratory distress. It's not always the trach, and sometimes we get a little tunnel vision. But no one's going to fault you for walking the algorithm to this point, especially if you feel like the trach was the problem initially. So, reasons why you may want or need to intubate from above, okay? So remember, with a laryngectomy, that's not possible. This is your only point of access to the lungs. But say your patient has removed the trach before you get there, okay? And you can't get anything back in it. It's possible, right? You can always go down sizes on your ET tube, but if you can't get anything in, you may need to consider intubating from above if they're in respiratory distress. Be prepared for a difficult airway. If the patient had their trach for, say, head and neck cancer, they've had radiation potentially, or significant surgeries. Bleeding might be another reason why you need to intubate from above to secure the airway if you're having a significant amount of bleeding from the trach. And then another reason might be, and something that it's important that you know, is if this trach has been placed within, I would say, the first few weeks, certainly less than 10 days, but I would be cautious anything less than 2 to 3 weeks. You can very easily, with a bougie, with an ET tube, or with a trach, instead of following the surgical hole, it's into the trachea, it's very easy to dissect along the fascial planes or in the soft tissue of the neck. So we really, if it's less than 10 days old, we don't recommend you are putting anything in the neck because of the potential for doing that. And if you do that, then you have lost the airway. And once you create that potential track or that false track, it's very difficult to back up and get it into the trachea. And now you have no airway access from the stoma. So if it's a very fresh trach, instead of putting anything in here, you may consider intubating from above. But anytime you want to put anything into the stoma, I really want to encourage you to always use your bougie, because you're going to get some tactile feedback from that, and you'll just feel more confident you're in the right place. All right, thank you for watching our video about how to manage respiratory distress with a trach. If you have any other questions or any feedback for us, please do let us know, and we'll see you in the next video.